So, systemic management for this has changed dramatically. Like every other case we've talked about, we've witnessed these incredible shifts in the past 12 to 24 months that have all popped up in the New England Journal of Medicine. We have Keynote 189, which was, again, a very clean study of adding immunotherapy to carboplatin pimatrexid versus carboplatin pimatrexid alone. It was asking a simple question. Patients were allowed to be on maintenance pimatrexid and pembrolizumab. And, I came out very early on before this trial was presented saying that maybe we would see a PFS advantage, but not an OS advantage. We saw a PFS advantage and we saw an OS advantage with a hazard ratio 0.49, which is unheard of in a driver-negative patient population. I think that shocked a lot of us and has clearly cemented this therapy, whether you call it carboplatin, pimatrexid, pembrolizumab, or triplet therapy, or PCP is the new acronym, has really been the regimen that has been standard for most of our patients. I want to talk briefly about the regimen, your experience with it, and have you had good results or toxicity concerns with giving these three drugs together?
So I think this has sort of become bread and butter for my practice with patients, especially like this gentleman in this case we're discussing here. I think what I explain to my patients is that initially when you're getting the three drugs up front, you may have more symptoms with nausea, vomiting, fatigue, cytopenias, but then when you're on the maintenance portion, it may seem a little bit lighter, treatments are much shorter. So most of the toxicity that I've experienced has been in the upfront setting, and maintenance has been easier.
One of the things I think it's important in this trial, and I get a lot of questions from community oncologists, well, the PD-L1, and this goes back to PD-L1 testing, does it matter? A third of these patients in this trial had a PD-L1 less than 1%, and that subgroup derived a meaningful benefit. Do you have to coach your patient? Your patients say, well, I'm PD-L1 0. Why are you giving me this regimen? Is that a conversation that comes up at all?
So some of my patients, especially the ones that are very well versed, do question me about that, and I do end up exploring the data and the subset analysis that has transpired, and I think it's a shared decision making that needs to occur. But they did gain a benefit, and I think that it is, I think it is something to explore with them.
Yeah, and so there's been one more trial that it maybe just got FDA approval again, New England Journal of Medicine paper, and a new regimen that has made it into the forefront, which is the IMpower 150. You and I were we were talking about this before the discussion about whether we should use this regimen or not. Patients, again, who were stage 4 were randomized into 3 arms. The focus of the trial, again, is on 2 arms, same theme, adding immunotherapy to a platinum doublet backbone and comparing it to a platinum doublet backbone alone. This platinum doublet happens to be in combination with bevacizumab, the old ECOG 4599 standard. And again, we saw by adding atezo to carboplatin paclitaxel bevacizumab quadruplet regimen, there was an improvement in survival compared to carboplatin paclitaxel and bevacizumab alone. Again, this was a Bev-eligible patient population only. There was an improvement in progression-free survival, and there was an improvement in overall survival. What was some interesting hints from this trial that run counter to everything else I've said about immunotherapy in EGFR mutant lung cancer. We know that single agent immunotherapy in EGFR mutant lung cancer is a lousy drug, but yet in this trial allowed EGFR positive patients, and if we were to apply everything we knew before, we would think there's no way that adding atezo would do anything to these patients, but this was the one study where we saw a benefit in the EGFR mutant subset in combination with carboplatin paclitaxel bevacizumab. This is not single agent immunotherapy. These are 4 drugs. It's elicited a lot of back and forth, a tremendous amount of Twitter arguments on whether these regimens should be used, but it is now FDA approved. And interestingly, the FDA excluded EGFR mutant patients from the approval. So not ready to be used for EGFR mutant patients. Certainly, I think it's a consideration without the FDA approval, given the data we saw. And then I just want to mention one more trial, which is the CheckMate 227, not to get too complex, but asking a question, does dual checkpoint blockade outperform chemotherapy in patients with a high TMB? Tumor mutation burden may be a biomarker that is predictive of outcome for patients with immunotherapy. This was a trial looking again at Nivo and Ipi, a wonderful combination I hear in melanoma, and comparing that to chemotherapy, specifically in patients with high TMB that are stage 4. We saw an improvement in progression-free survival, but we did not see an improvement in overall survival. We would have loved to see an improvement in overall survival, given this is a neat little biomarker that has a lot of science behind it.